Good morning, and thank you for having us here. We're excited to present today. Ben Hilliard and I are here from Aloft Integrated Wellness, and Melissa Hanlon is here from Soloway and Hollis. We'll go through some brief speaker background and introductions, and then we will move into the learning objectives for today.
Hi, my name is Ben Hilliard. I'm a mental health provider. Work with kids and families and mental health providers. Been doing it for about 30 years. Thank you very much.
Jessica Lyons, along with Ben, I'm the co-founder of Aloft Integrated Wellness. I am a licensed marriage and family therapist. I've been in the field for around 20 years. I'm also an adjunct professor at UNH in the Department of Human Development and Family Studies, and we are excited to be here representing the mental health and behavioral health perspective of the model that we will present on.
Good morning, Melissa Hanlon. I'm a healthcare attorney at Soloway and Hollis. I defend physicians and hospitals and other healthcare providers in medical malpractice cases and before administrative boards in both New Hampshire and Maine, and I've been doing that work for 20 years. Thank you. So I want to go over briefly the learning objectives for this morning. We are going to go through some key concepts and core principles of an integrated behavioral health model so that everyone understands the framework we're talking about. And then we'll explain how integrated behavioral health care differs from the traditional models of healthcare and what the current practices are in an integrated healthcare space. And finally, we will identify ways that this model promotes risk management improvement for providers and where the risk issues are.
Okay. Ben and I have both practiced in community mental health settings as well as private practice. In 2019, we co-founded Aloft Integrated Wellness, and we were awarded funding for a pilot program through the IDN Integrated Delivery Network in the state of New Hampshire to establish a new model of care embedded within a pediatric and adolescent medicine program. We partnered with core physicians, and we have been embedded on site at the Stratham, New Hampshire office location since early 2020, right before the pandemic started. So as we present this model, one thing we do want to acknowledge is that we sort of started and then COVID happened and we had to completely adapt and restructure the workflow, and then we got back in office in a more traditional sense. So it was not the smoothest start, but we will explain the model that we developed and ultimately implement it, as well as the learning that has come out of that.
So to go back to look at the traditional model, I think is a good place to start, because mental health, permeates all parts of our population. With our kids, our adults, our families, we see endless referrals coming into us with basically crying parents, difficult situations, and the workforce is overwhelmed. If you think about the traditional model, you think, especially in pediatrics, the parent is the central communicator between the different providers. So parents often tell us that they have to get the recommendations, the treatment plan from their mental health provider that goes to their medical provider. The medical provider gives them recommendations or treatments. They may have a psychiatrist, they may have educational professionals with special ed or 504, and they're looking at they have to go around to all these different providers. And a lot of these different providers have different languages. So it's very, very difficult for the parent to figure out the solid, quick, effective pathway through the treatment of their kids.
So what we found in developing our model, which is a combination of integrated care and what is referred to as COCM, that we will explain a little bit more on later, what we found is that this model aims to address two primary pain points. So one pain point being what Ben just described, which is that in the traditional model, a parent and their child will present at the pediatrician with the pediatrician, and the pediatrician typically will give them a list of mental health providers in the community, and that may or may not include psychiatrists, medication prescribers, and or therapists. And then from there, parents make 30 phone calls. They might get 2 calls back. The entire time the pediatrician is concerned about their patient and awaiting for this next level of intervention and support. So the pain really falls on the pediatrician, on the medical team, as well as on the parent and the family. Traditionally, mental health has been siloed from primary care. There also are significant access to care challenges. And significant workforce shortages. So you see specifically a workforce shortage relative to psychiatric providers. In particular, there's a shortage of psychiatric providers that have training to work with children and adolescents. And there's also a shortage of licensed clinical health, mental health providers. Certainly COVID has catalyzed these trends. Prior to COVID, we had surveyed a group of pediatricians in our community, and at the time they estimated that approximately 25% of their daily visits had a behavioral health component. During COVID and since COVID, that same group of respondents let us know that their estimate is that about 75% of their daily visits have a behavioral health or mental health component. So we see the need for this even greater than before. We also know that 1 in 5 children has a diagnosable mental health disorder. And again, so often the burden is placed on the primary care physician, on the patient and the family, the parents, and also schools. We'll touch on this a little bit later, but our model also has built out a space for collaboration with the school so that we're really looking at the whole child and creating a shared language across the various communities that children and their families exist within. So I want to give you an overview of what the day-to-day looks like under this model. So as I mentioned before, we've taken an integrated approach, so an integrated behavioral health care model, where we have on site every day alongside with the pediatricians, we have a licensed mental health provider, and then we also have a bachelor's level social worker. And so we refer to those two individuals. The licensed clinician is referred to as the BHC, or the behavioral health consultant. That's typically a master's level licensed individual. And then we also have a care manager. You find sometimes in integrated care, this is also referred to as an enhanced care coordinator. So both of those individuals are on site and function as part of the pediatric team. And then during daily visits, the pediatric team might flag in the morning during a daily huddle. They might flag the patient list for the day and say, we want someone from the team to be available approximately at this time. This is a family that has higher needs, or there are ongoing behavioral health diagnoses in place. And then additionally, if at any point during the day, a visit presents with a behavioral health concern, and a behavioral health concern can be very broad. That could be a parent who isn't certain whether or not a behavioral symptom that they're seeing in their child, perhaps is it developmentally typical, or perhaps does it raise to the level of anxiety. This also might include a parent who's presenting with concerns about their child's sleep or changes in their eating habits. So when a concern like that gets presented to the pediatrician, typically what happens next is the pediatrician pauses the visit and then calls in a member from the ALOFT team, so either the care manager or the behavioral health consultant. And then one of those individuals comes in and runs the visit alongside the pediatrician. And typically what we do is we immediately spend some time with the family. We provide some brief psychoeducation, and we often send out screeners that will better capture the symptom presentation and identify next steps. So in the integrated care model, this is referred to as a warm handoff. So that is the handoff from the pediatric provider over to the behavioral health team. And again, this is a departure from the typical model wherein typically the pediatric team is holding the responsibility to address these problems and assess these problems. And often might just provide the parent with some additional resources to follow up with on their own. So during the daily visit, we have someone, typically 2 members of our team on site, on staff there, and they're working throughout the day with the pediatric team, really not operating separate in any way. We also do what we refer to as curbside consults. So in some cases, the behavioral health team is not necessarily interacting specifically shoulder to shoulder with the same patients, but the pediatric team might report out to the behavioral health care team changes that they're noticing, or even in some cases just trends that they're noticing with their patient population, and that sometimes prompts us to put together some additional resources. In the past, we've run groups in response to trends that we're seeing among the patient panel. And so in this model, we also have our weekly consult with a psychiatric provider. So we have a psychiatrist who's actually stationed in Colorado that Zooms in with our team once a week for 1 hour. And in that situation, we have a docket of cases to review that is identified ahead of time. And we go through cases collaboratively as a team. We discuss potentially onboarding medication, med changes, diagnostic clarification, Sometimes as a team, we discuss which therapeutic interventions might be best. So if we notice that, for example, a patient who has been engaged in short-term cognitive behavioral therapy perhaps isn't making the progress that the team would like to see, we talk as a team about what shifts can we make in the treatment planning and in the clinical intervention. And in some cases, when appropriate, we also will gather information from the educational supports, attending IEP meetings, reviewing IEP documentation. Of course, this is all coordinated with appropriate releases and consents in place. But we have also built into our model a way to include the educational system as well to look at the larger picture of the child's overall health.
Maybe we should talk a little bit about some of the impact of some of those meetings.
Yeah, that would be great.
It's hard to really describe, but in 30 years of practice, I've never seen in a more effective way of doing really good work. For example, a Friday warm handoff with a potential ADHD diagnosis, and in 3 weeks we have the child on a perfect medication for the child. Didn't have to increase it. The child was going from maybe I think it was like C's at her school up to A's. And we're not always looking at just adding medications. And one point, because we had some information about this from the school, we had differing information from a divorced parent team. We would have likely put the child on a higher level of medication, but because we had information from all these different levels, we found out that it wasn't necessary, so we actually didn't increase the medication. It's really, really profound.
And that was a case in particular that many of the doctors, cases like that, doctors will say, these are the cases that keep us up at night. Or in many cases, this case in particular, I believe the pediatrician we were working with said we accomplished in 3 weeks what typically would have taken 6 months.
And a lot of driving around by the parent as well.
Yes, yeah, taking time out of work to take their child to different visits and appointments, and then the burden being placed on the parent to communicate back to the various providers.
And we have some testimonies later, but we'll go into kind of a little bit more detail about how our workflows work. And this slide is actually very complex because the process is very complex. What happens is that when we get a referral, we have information from the doctor, we look through that, we then assess what we can do with it. Then we get releases, we send out information to schools. We use a product called Mira that does HIPAA compliant online program or software that sends out scales. I believe they have about 50 children.
They have about 50 that are validated with the pediatric and adolescent population, and it's referred to as a measurement-based care protocol. So you might sometimes see references to MBC. So this is the use of things like the PHQ-9 screener or the GAD-7 screener, screeners that are statistically and empirically validated, and really help capture not only symptom presentation, but also progress and change over time. So we use this software. It's typically one of the first things that we do is we dispatch these screeners. Some of them might go to the parents, some go to the child depending on the age, and in some cases they can actually go to the educational professionals. And then this is the criteria that we typically use in our Wednesday psychiatric consult meeting. We pull up a screen and we look at the overall scores. We might discuss as a team, what data have we not captured? So do we want to send out some additional screeners to explore some other symptom presentations? And then we use this as a basis for measuring change over time and responsivity to the shared care plan across the team. So we notice if the scores start to trend in a direction that would flag an increase in severity, that prompts the team to put that patient on the weekly agenda with a psychiatrist, and then as a team we discuss perhaps what changes we need to make in the treatment planning, or what other factors might be influencing the symptom presentation or the lack of response to the existing care plan. And again, I think something really important to mention is that under this model, under the integrated care model combined with COCM billing codes, the only criteria for the COCM model is for the patient to have a behavioral health diagnosis. So these patients do not need to have medication. And in fact, as a team, our priority is to use the least amount of medication to get the most efficient results. The psychiatrist that we work with, one of the things that we really value about her is that she really looks to, in many cases, off-board medication.
Deprescribe.
Deprescribing is really an area of her expertise. So often, again, because this model traditionally has been delivered, mental health services have traditionally been delivered in such a siloed manner, where the prescriber doesn't always have access to the perspective of the school or the perspective of the primary care physician that has been with the family perhaps the child's whole life. Sometimes what we see is children prescribed a number of different medications at varying doses. So in our Wednesday meeting, it is not at all uncommon for us to discuss reducing or eliminating medication. And we typically measure efficacy through the use of this measurement-based care protocol. And again, the software that we use specifically is Mira. We might talk a little bit about that later. But that's often one of those first-line interventions, is that we send out the validated scales. In some cases, the pediatrician says, here are the scales that I would like you to send. In other cases, just as a team, we confer with one another and then dispatch those screeners.
And in general, what we try to do is to look at sort of a broad range look to kind of get an idea of what's going on, because many diagnoses have similar symptoms and criteria. So we take a broad range look, and then with clinical sort of expertise, we then refine and try to figure out what the most appropriate thing we can get the measurement-based care results for, and also see the treatment progress. And it's important for us that we don't leave out just the parents, so we actually add a scale for parents, and it's called the Caregiver Strain Index. And what that gives us is, it gives us a look at what the child is doing in response to treatment, but also where the parent strain is, and it gives us kind of a unique look at the full picture. Back to this slide, what we try to do is what we found out how we're doing this for the last 6 months to 2 years, is that we found that more and more information is being needed in those meetings. Mm-hmm. As mental health providers, we never thought that weight would be a really important
thing that you would need quick access
to. And that's based on the type of medication, the milligrams of medication, some of the medications. So the LOFT providers, the care manager, we develop from the records and our own assessments, we develop an assessment that it prepares the case for the COCM meeting time, the psychiatric consulting time.
So that we have ready access to that information. I think we've gotten better over time at predicting the questions that the psychiatrist might have and that the pediatrician might have. So we do that prep prior to Wednesday's meeting, because to get an hour of time with a psychiatrist is not a small feat.
Right.
And so we try to maximize that time as much as possible. So we prepare a document ahead of time. We have quick access. And then, of course, we fall back on the medical record as well, which we have access to during the meeting.
So we're highly prepared for that meeting, but we then take this document during the meeting and actually add in the recommendations from the psychiatrist, the recommendations from the therapist, the recommendations from the pediatrician. We're putting all those three different, and the care manager, who all have a different view of the same situation. We should put it together to develop a shared care plan.
And typically also clearly identified next steps. So when we, as a team, say this patient should follow up with the pediatrician, we get as specific as who will make that call and what is the time frame for that follow-up. Sometimes it's the pediatrician following up, sometimes it's the behavioral health care consultant. So various members of the team might follow up. One thing that's important to note, certainly the focus of today's presentation is on the model and on the risk management perspective associated with a shift towards a model that is integrated. But in terms of billing, one thing that we will note is that the COCM billing does operate based on the amount of time spent per month. So we are also, as we're doing all of this workflow, we are also logging and documenting the cumulative time throughout the month, because at the end of the month, the billing closes out and is submitted based on the total billing, total amount of time being spent collaborating among the providers and with the family. And so even things along the lines of our Wednesday meetings, the time spent reviewing a case counts towards the COCM monthly billing.
And phone calls and outreach, setting up the scales, interpreting the scales, warm handoffs, case cut. It's really that extra time between sessions and appointments that has never been really accurately captured. In 2.5 months, with less than 10 patients, we collected over 41 hours of time.
Yeah.
That's rarely been billed before.
And I think that's a big part of why you weren't seeing models like this previously. I think most people would agree that this is best practice for there to be a shared understanding across providers. But the workflow around that was not so clearly defined, and until very recently, until CMS launched these codes, there was not a way to accurately bill and get reimbursement to do this type of work.
So after that first initial meeting with the psychiatric consultant, we then have scheduled out the mirror scales, and that's based on severity. So if it's a really acute kid with acute issues, then we would send out scales on a weekly basis. If it's a medication, initiation of medication, then we might do that on a bi-weekly basis. If it's a child that's not responding to therapy and they have an every other week sessions, we might do it once a month. So we base that sort of scheduling of the scales based on both the symptoms that we found, look at getting those measurement-based care results, and also treating the child, specifically to what the issues are. So then that review time, depends. It might be we see one kid we talk about every 2 weeks. Some kids we actually don't have a lot of conversations about because they're doing quite well. And some, maybe I'd say the average is probably once a month, I think.
Yes, yeah. A few months into doing this model and implementing the model, one of the things that we started to recognize is that very often medical issues are presented to the behavioral health care team, and the behavioral health care team often is interfacing with the patient at higher frequency and for longer durations than the pediatric medical team. And again, in this model, we're working together as a team, and it is a very integrated approach. But in terms of frequency of visits and interfacing, you often see the behavioral health team or the care manager checking in more frequently than the pediatric team. So we developed what we refer to as a reverse referral form. So in the traditional model, even in the integrated care traditional model, the pediatrician usually is the first person who identifies a behavioral health concern, and then they, through a warm handoff or a referral, tag in the behavioral health branch of the team. What we do is we have a vetted list of common presenting problems that the clinical team, the behavioral health care team, might pick up on, that we can flag to hand back to the medical team. So it's not just a one-directional referral workflow. So we did work with the team to identify and vet a list of common issues that the behavioral health branch of the team might notice, and then we submit a form back. Typically in our workflow, we send it to the medical assistant, who then will do outreach to the family and book a sooner visit. And so this also assists with recommendations, compliance, follow through, and it also increases the continuity of care. And just to give you a few examples and some overview, certainly if there's a new medication onboarded or if there's a change in the medication dosage, we make sure that we're screening for side effects, we're screening for response, any challenges. So for example, some medications disrupt appetite, some medications can disrupt sleep. So our team watches for those side effects very, very closely. We also screen for things like fatigue or menstrual difficulties. We screen for things like weight loss or weight gain, GI issues, bedwetting, any concerns about other needs that the child has that are unmet, or recent head injuries, perhaps from sports. When those topics are identified, we complete a reverse referral form, typically get it over to the med assistant, who might consult with the pediatrician and or do some outreach to the family to book a sooner medical follow-up, so that we don't waste time responding to those identified issues.
And if I could just add to one thing, a lot of these issues both show up as a medical issue and a mental health issue, and some of them give us clues of what the diagnosis is, but also gets that child back into that pediatrician immediately, and parents are very, very thankful for it.
And from a risk management point of view, I'm going to talk at the conclusion of the presentation about sort of the benefits and risk points of this model of care, but this is one of the places where I wanted to highlight a true benefit for a program like this, because you have more eyes on the patient and you're capitalizing on that by sharing the information in a really effective and impactful way for the patient. So if the mental health providers are now referring back to the pediatrician for potential health issues, you're getting those health issues addressed more quickly and efficiently than under the traditional model of care.
So in our model, we looked at the collaborative care billing codes and noticed that they are written very vaguely, and that was done on purpose. We vetted this through a lot of different organizations that work on this, and what we do is we accrue time with both the behavioral health consultant and the care manager. In the pediatric population, that amounts to a lot of information, a lot of communication with parents, communication between providers, and reaches those the minimums for the billing codes quite quickly. You have to be cautious about this because you can't double count time. So if a care manager and the behavioral health consultant is in the same room doing the same thing, we only count for the care manager's time, so we don't double bill that, and that's super important.
Sounds like lawyer billing restrictions, Matt.
Well, to be honest, sometimes we feel like we
Yes.
need that little lawyer button that starts
Yeah.
the time, you know, because the registry is a place where we count that, and basically I have to make sure it's working, and it's complex. So when we've learned is that parents feel more surrounded with a informed team, which is very, very important part of our work and what drives us to get this work done. We also have less miscommunications between providers because we have these two folks on the ground. And also when we have our behavioral health consultant within a kind of traditional mental health session, we still have the care manager available for warm handoffs, curbside consults, or updates about care.
Just wanted to give you a little bit more background about the measurement-based care protocol that we use. So again, we work with a company called Mira. We've been really, really happy with them. It's been a wonderful product with a number of validated instruments going down as young as 4 years old. So when we're working with patients as young as 4, we have access to validated screening instruments. As I mentioned before, some of them just go to parents, some of them go to children depending on the age, and then some also can go to educational professionals. And this helps us capture symptom presentation and change over time. We find that this creates shared language across all of the providers on the team. As Ben mentioned before, typically in the mental health field and in the pediatric field, there has not been shared language. And so this really gives us access to shared language and a shared understanding of the symptom presentation. We also have noted in connecting with other integrated care programs and other COCM models, COCM specifically is more well defined at this stage of the game among the adult population. But in the connections that we've managed to have with other COCM programs, one thing that is being discussed widely in healthcare currently is that the use of measurement-based care and integrated care specifically really well positions healthcare organizations for population health and value-based reimbursements. So this really lets us capture things like social determinant of health information, symptom presentation, parent or caregiver strain, as well as responsivity to the shared care plan.
We have a couple testimonials for you. This first one is from a nurse that we work with in the pediatric practice, and she said, "This model increases patients' follow-up access and timely care consultation." And this is another testimony from a pediatrician in the same office. "Patients have to wait weeks, not months. Alleviate access, which saves lives, decreases stigma, and increases whole child view."
One thing that we also wanted to share is certainly most of you are familiar with the exacerbation of mental health concerns and crisis among the pediatric and adolescent population, in particular exacerbated by COVID. So during a time that self-harm among adolescent females in particular increased 51%, we found in this model, working with hundreds of patients, I believe to date we've received about 550 referrals under this program. We've only ever had one patient utilize the emergency department during this entire time. So the
and that one, we pushed that one.
Yes,
back.
that was one that we pushed because there were some medical components to it. So as a team, we made the decision to refer to use
With
of the emergency
with
department.
the pediatrician, and, yeah.
Yeah. So this model, because it's so responsive, ideally is also designed to keep kids out of the emergency department and in some cases out of inpatient hospitalization. We have found that we have had to date 15 families who have changed care from other providers to come into this pediatric program specifically to access this model and this care. So this is a testimonial from a parent of 2 teens. We recently moved our kids from their longtime practice to Core Pediatrics specifically because of the relationship and program with Aloft. As a parent, it is an extremely reassuring feeling knowing that the pediatrician would mesh and intersect with counseling efforts as well as other specialties as needed. Aloft and Core Pediatrics look at care holistically, which simply makes sense. We can't believe we waited so long to get involved with an integrated approach.
And then the final parent testimonial we've included in this slideshow is from the parent of a 10-year-old. As a parent with a child who has ADHD and anxiety, it can be extremely difficult and defeating at times to try and address all the things that go along with the diagnosis. Finding doctors, psychiatrists, or psychologists, working through different medications for different things, keeping the communication up to date between all these people can be so time-consuming and overwhelming. Coming to Aloft and having the connection to our primary care doctor at Core has honestly lifted a huge weight off of our shoulders and given us the opportunity to take a breath and be better parents to help our son be the best kid he can be. So now we're going to turn to talk about some of the risk management issues associated with this, and of course, again, revisiting what the difference is between the traditional model and this model of care. So traditionally, we often see the pediatricians might have incomplete information despite the expectation that they are well informed. We've seen little collaboration with all of it filtered through the parent, as we've discussed, and difficulty with the parents at navigating the resources, and also a potential issue that the parents and caregivers are not always a reliable source of information. So relying on the parent to provide feedback as to what the psychiatrist is saying or what the therapist is saying can be fraught with risk for providers because they don't have the actual information from those perspectives. It's getting filtered through a parent who may or may not understand it and may or may not be able to effectively communicate it. So where do we see potential risk issues? So everyone here is familiar with the risks of curbside consultations in healthcare. You know, if you're providing a curbside consultation, do you have a physician-patient relationship, and what are your responsibilities in terms of the standard of care and providing the treatment from there? I think one of the benefits of this model is that there are clearly defined roles and expectations, and so the benefit and the limitations of that curbside consult are really have clear boundaries and parameters, whereas a typical hospital curbside consult may not have those clear boundaries and parameters, and that provides some protection for that curbside consultant. You may also see a claim about supervisory roles of providers or respondeat superior claims. So here we have 2 different organizations coexisting together with different employment and contractual relationships. And so there is always the potential the pediatrician could be pulled into a claim. They're acting in a supervisory role to the mental health providers or the care managers, when that might not actually be the case. Here they're all equal team members, not supervisors and designees. Again, I think having these roles clearly delineated and having a very good understanding of what the expectations are for each role and what the limitations are for each role will mitigate that risk. And then the collaboration and shared responsibility issues. So this is something we've seen a lot more of with the genesis of electronic health records. If something is in another provider's record that you have access to, are you therein responsible for knowing that information, even if it might not be something you would traditionally look at? Again, because we're really increasing the flow of information among the team, and we have existing systems under this model for how that information is going to be shared and where it's going to be accessible to every member of the team, I think you really minimize that risk. And then again, the consultant role, which is similar to the curbside consult. So what are the best practices? Some of them I've already touched on. So I think in an integrated healthcare model from a risk management perspective, it's really important to have clearly defined roles and responsibilities. What is each team member's role? What are their responsibilities? And how are they going to effectively share information and execute their part of this team and this plan? you want to have a clearly defined method for sharing the information and ensure adherence to it. So again, if we have a shared medical record or we have shared information that's being used to prepare for the collaborative case consult that's happening once a week, then you want to make sure that everyone is following that workflow in a reliable way. And then have a system in place to make sure the providers are all aware of changes. So this is that reverse referral model, right? So a way for the healthcare providers to know from the mental health providers what changes they're seeing in the patient that could be of concern, and also a way for the healthcare provider to share that information with the mental health provider. So you see a lot more knowledge shared among the team. Everyone has eyes on the patient, and everyone is sharing their observations and their concerns about the patient. So the hope is it will be really impactful for that patient, and I think, as Jess and Ben have said, we've seen that come to fruition. At this time, we would like to invite people to ask questions. Thank you so much.
Thank you.
Thank you.